If it's a billing question, we may just say, unfortunately, that is something that you'll have to figure out with the billers at your practice and with the payers. That's why, especially with like the billing drop-in, we like to offer that as a resource for everyone to talk to each other. If you have other practices in your areas that you can work with and figure out if they can, the magic sauce to get through and get these things to payers and get them paid.
Has anybody here been to a drop-in?
I mean, I can see some, but I'll ask the question Jan asked me. Has anyone here been to a drop-in? Wonderful. That is a huge percentage. So please keep coming. We like having you guys there. So in general, we have so many updates that get tossed every year at us, and kind of what we are going to be looking at today, that we tried to slim this down to be PEDS specific. We don't have enough time to go through everything every single year for all of the changes, because a lot of it, again, doesn't really apply to you all. So generally what we're going to be looking at is the stuff that came in as far as ICD. These are rules that came in. They were effective 10/1 of 24. So that's when the rule set comes out for ICD. As a note, we have had mid-year updates. I will talk about that at the end of the presentation. Of course, the time for this is wonderful. We had July 1st updates that came out that I'm just going to point you towards, and we are going to flesh that out a little bit more. I think we're totally going to be providing that at the August drop-in, the August 21st. So we're going to have a little bit more information on there. Specifically about what stuff has come in for July 1st. But these are the ones that have come in as effective as of October 1st. These are going to be the references here. They should be able to click on these if you have the slides downloaded. These are just the the places where these resources are provided from ICD. Also has the addenda file. That's kind of what you're looking for. The addenda is going to be your changes that have happened. Those are highlighted. Usually they'll have a PDF that's, I know the most recent one was something like 50 pages long around there that goes through everything that was updated. Again, this link I have to check to see the history of this link again, because we're getting these sent in before the July 1st updates came in. But that page, if you're looking around, you'll see that they have 2026 specific updates that they're putting in for those. So to get started, we have Chapter 4 is endocrine, nutritional, and metabolic diseases. These are going to be your diabetes codes that are here. For this, we've got the whole range is the E range for codes, and we have E10.64 hypoglycemia. It's use additional code for hypoglycemia level if applicable. E16A. More endocrine stuff that we're looking at. Again, these are codes that are being usually expanded on. So we may have like the upper code here that exists for a while, but it's expanding out to provide more specificity for these. Again, having stage 1, stage 2. And then continuing more of these, overweight and obesity. One of the big changes for some of the stuff with obesity is that they have added different levels for the percentages for this, for the different classes. I think we get into that we have the ranges. That was something that happened earlier in the year that you may have noticed your ranges that you're diagnosing patients at. They've added percentiles where those got broken out further. So you have where a patient may have been in I think what was the lower percentage? It was 75% up to
90 plus maybe?
Yeah, it was something along 90 plus. They have expanded those out, so they added more breakpoints essentially throughout where you could have that diagnosis for it.
Oh, 120 to 140.
Excuse me, so they expanded beyond it. So they've added more, so it's 120 to 140.
Class 3 is 140 plus.
Yeah. Sorry.
I'll get better at this, I swear.
Yes. So yeah, so class 2, 120 to 140 of the 95th percentile, or a BMI of over 35 kilograms to less than 40 kilograms, which is, whichever is lower based on age and sex. And then class 3 is over 140% of the 95th percentile of BMI. This year added new codes for anorexia nervosa. Again, added more specificity. If you could turn that down, I appreciate that, Tom. So we added, again, more specificity for this, again, adding categories for the, dependent on patient BMI as well. So we have, 17 plus, 16 to 16.99, and then 15 to 15.99, and then less than 15. So these are all new codes that were added for this year. Again, on here they're listing mild, moderate, severe, extreme, and then they also have intermission and unspecified. This also applied for anorexia nervosa, binge eating / purging type. Again, same categories are off of those numbers of 17 plus, et cetera, going down through, with your mild going down through to extreme.
And the addition I'd just like to make to this is, as we're adding the benefit or the difference in these categories and ranges, that's your clue to start trying to get into the habit, if you're not already, of including those in your documentation, because that's going to be the thing that supports reporting these codes. So if ever you're invited to an audit, the mismatch is less likely if you've got these ranges somewhere listed in your document, in your encounter documents.
Again, we have the same categorization, if I can speak properly. This is me jumbling my words. Again, with mild, moderate, severe, and extreme for the number of episodes per week for binge eating. Again, that mild 1 to 3, 4 to 7, 8 to 13, and 14 plus. One thing to note for this, this is in particular is actually not a new code. The F98, what it is it's added new symptoms to it. So sometimes ICD will do this where they don't, the code itself hasn't technically changed, but they're adding more specificity about what symptoms should be included for this. So as a note, again, these are, you'll see we have add. So if you ever see the documentation we send out, we generally try to keep the verbiage that's used on the updates that are sent out where it will say add. We may say new codes or something along those lines. But here when it says add, you'll have this line that has been added for this particular year. And then you'll also see we have an add excludes, which doesn't sound right, but it's just because they've added that exclusion for this particular code. These are new codes for J34.8. More specificity for the internal nasal valve collapse. We have those going all the way out to, I think it was 8212 is the highest number that we have for these that are being expanded out. And I think that's all I have for notes for this. So caveat for this, we still need to look through and verify that there are any more guideline changes that have come in the July update, but as of October, we don't have anything new for outpatient pediatric changes for nothing really meaningful guideline-wise that you'll need to be looking at. On to CPT changes. So these changes, again, were effective January 1st, 2025. Main changes that I have seen, and I'll put a huge caveat on these, is our E&M codes that have changed the telemedicine codes. You may or may not have had much luck getting these paid. We have noticed a lot of payers, I know UHC in particular, has put out documentation to state that they still want you to be sending the codes out with a normal in-office code, like a 99213, with a telemedicine modifier. That hurts my brain because we have very specific codes that have been created to give exact specificity about what you are actually doing. However, again, coding versus billing. Coding side would say these are the correct codes to use because it's accurately describing the care that you're providing. However, payers may still say, well, our systems aren't updated or we just don't want to deal with using new codes. So we're going to have you send the old stuff with modifiers and continue to do that. This first section is synchronous audio video, E&M. This is for new patient series. So again, for all of these, when you're looking at them, they will have a time marker in addition. Later on in the slides, we'll also push the new 2025 E&M coding tool that we have worked on, and that is something that you can get on our website. And that is also including a time section for these. These can be coded based off of E&M or time. There is a time listed here, but that does not mean that that's the only way that you can code these telemedicine visits. So it is, again, medical decision making or time, and you'll have to follow these time guidelines. Like everything else, this includes the total time on the date of service. So if you're doing anything from reviewing your charts, reviewing the records before the patient comes in, if you're doing the follow-up, you're calling the parent on the phone, all of that time can be counted towards this. So if your phone call was only 20 minutes for the actual, or the video call was only 20 minutes that you were working on with this patient, if you have other follow-up or their charting tasks, that also can be counted towards that time. Yeah, absolutely.
One of the interesting bits about this new set of codes is that if you, we've had a question occasionally where if you begin an encounter with synchronous audio video and then the video gives out, you've got a patient with either an unstable connection or for whatever reason you end up with audio only, the current wisdom on this is to code using the CPT that represents 50% or more of what the duration. So if you had a 20-minute visit and 15 minutes of it was video and the last 5 minutes was audio, bill it as a synchronous audio video. So whatever was the prevailing majority time spent, whatever modality or connectivity type was the majority of the visit is what you should code.
Continue on, we have, again, same thing for established patients for your new telemed codes for audio video. Again, this is going to be your standard video calls that most practices are using. Next section we have is for new patients of audio only. One thing to note for these is that it will state with medically appropriate history or exam, at least 10 minutes of medical discussion required. We'll see that in a few slides, but there is actually a different code to use if you are only on the phone for the patient between 5 and 10 minutes as opposed to reaching that 10-minute plus mark of medical discussion. You would actually use a different code for this. So again, keeping track of the amount of time that you're spending on the phone with the patient, getting that medically appropriate discussion. The other ones, again, those were straight medical decision making. It could be a shorter phone call, but it's based off of the MDM. This is the only section with the audio only that actually requires that the discussion length actually reach that 10-minute mark. So just keep that in mind if you are going to use these codes. Same thing for established patient. It still has that 10 minutes of medical discussion required for these as well. This is the code I was mentioning. So the 98016 is, again, that brief communication. So if you've got something, MD or QHCP who can report E&Ms, who had that medical discussion between 5 and 10 minutes, this is the code that you would use. One thing to note for this as well is that there are limitations on when you can bill this out. Basically, if you have you have not had an E&M procedure in the last 7 days, and this call does not lead to an E&M procedure within the next 24 hours, then you can use this. So if this is a phone call where the patient calls you the night before, you schedule them for a visit the next day, this code cannot be used. You would just, not use it. You'd use the time, again, if it was same day. So if the patient was calling you in the morning and you had them come in that afternoon, if you were getting medical history on the phone with the patient, that could be counted towards your E&M time. But of note, if they had called the night before and you spoke with the family and they came in the following day, because it isn't on that same calendar day, you can't use that time. You can't count that time if you are going to code on time the following day. So it does have to be that same calendar day for that instance. We have a few grammatical changes. We've had qualified non-physician healthcare professional changed to non-physician qualified healthcare professional. Small note, but just wanted to pass that along for this.
We share those because if you see that a change happened, but it's not obvious to the eye, it's reassuring just to know it's grammatical. You can ignore it. Didn't change it meaningfully in one iota.
Yeah. We also have new codes for education for patient self-management. This is the 98960 through the 98962. This is essentially what can be a group session going for those 2 to 4 patients for the 98961, and 98962 is for 5 to 8. Again, education and training for patient self-management by non-physician QHCP using a standardized curriculum. And there is, again, a face-to-face with the patient. It could include the caregiver or family, but it does require the patient. And these are in blocks of time. So if you are billing this out, it's going to be each 30 minutes for that individual patient. If you were to be billing this out where they were in a group session and you had multiple patients at the same time that you were providing that education, you would send out one of the other codes noting how many individuals, how many patients were in during that education session, because I think that changes what what reimbursement is on this, and generally what pricing is for these, because you're doing it either on a one-to-one basis or you're doing it in a larger group. A little bit more information just on the telemed guidelines, unless you have something you want.
I do. I just have one chat. I'll answer in the chat as well, but someone that's attending virtually asked, will the 98016 count if our MD or NP checks in with a patient that was seen in the ED to see how they're doing, but they don't need an in-office visit? That would not be an appropriate use of this code, simply because the 98016 has to be patient-initiated. So this isn't a transitional care management kind of code. It's not that kind of check-in. This is if the patient calls you and you've got less than 5 to 10 minutes of medical discussion. That's all that's for. Great question. Thank you.
And also, if you have questions, please don't hesitate to raise your hand. We're making good time. So, yeah. Again, more information on the telemed codes we were talking about earlier, used in lieu of an in-person service. So if you're on the phone with a patient and they decide to come in, general recommendation, even if you were planning on this being a video call and doing that service that way, just as a telemed, if the patient does come in later that day because you feel that you really do want to get a physical exam, you can't use this code on top of the standard in-office E&M code. So the recommendation is, utilize that charting time, the time you spent on the phone. That's all countable time if you wanted to bill that way. But you just wouldn't be able to bill out both a telemed code and a standard in-office code for those patients. For this, it can be used as a follow-up. So if you did want to schedule a telemed visit for a follow-up, that's absolutely okay. The only one, again, like we mentioned before, is that 98016. That has to basically be that patient-initiated one, like Jan had mentioned about the follow-up. So you can't be following up. Again, more information about this is just if minimum time for reporting the telemed visit was not met, time spent with a patient may count towards total time on the date of service for an in-person. So again, if you had spoken on the phone before and they came into the office, that'll be there. Audio only telemed, I think we touched on this, 5 to 10 minutes of medical discussion, use your 98016, and video is not required for the audio only visits. Yeah, absolutely.
So if like we get a phone call from a family and my partner takes it and I end up seeing the patient, we get to count both of our times, or is it only if I count it?
Yeah, the question was that if a patient calls and you have one provider sees or initiates that phone call with the patient, or they're speaking with that patient, and then they come in and they're seeing another provider at the practice, can you bill both? The understanding is no, because you are one healthcare organization that's doing that. If they were calling one provider who wasn't associated with your practice, and then they just randomly came into your office and saw you, yes, those would be separately billable because you're not in the same organization, but because it's your practice as a whole, you'd only be able to bill for one for that day. You would be able to bundle the time. You'd be able to use the time that was used by that MD to add on for time for the other one, but you would not be able to bill them individually as like one telemed code and then one in-office code. Mm-hmm. Again, just more guidelines for this. Do not count the time performing telemed towards these other codes. The audio only, again, has to exceed the 10 minutes. and based on the medical discussion time, not your MDM for that 98016. Again, once you don't have the ability to do MDM for that length of time for audio-only visits. And again, slight note, if it's less than 5 minutes, it doesn't get reported. I believe we have talked about this, does not include, yeah, another note for this is that you do actually have to have live audio for this. This does not count if you're doing text messaging or emailing or any other kind of instant message type communication with that patient. They do have to be on the phone with you, or at least on an audio call through something online. You have to have live audio of that patient to be able to bill for these. You can't do text or otherwise. So, removal. So they've added those ones, they've removed these. We try to make that very clear with the very long strike-throughs for everything. If it's harder to read, again, these are on the app. You can feel free to download those and review these. But all these were removed. And this is what I was pushing earlier. So we have our 2025 E&M coding tool. If you haven't utilized this, we'd love for you to take a look. It just does guidelines and uses the AMA verbiage of how you would level these. It's basically something that you can print out if you want to circle. You've got where you can level your visits here, and then the different categories and what we would fall under for both your problem complexity, your data, and then your risk there. And then on top of that, for this year, we have added the backside of that page is going to be a time component listing. So before we had it over on the side for the 2024 and previous ones, but this year we've added, this is a whole separate page just because of the new telemed codes. So we have your office E&Ms on the left, you have your synchronous audio video codes in the middle, and then you have your synchronous audio only E&M over on the right-hand side. Again, those are also broken out. You have new patient, established patient for each of those columns. There isn't a link on that specifically. I think it's technically an info.pcc.com link, because I think the one you may find one on Learn that's the 2024, but we'll send that out. Maybe we'll get a thing in the chat. I think it's like an info.pcc.com version for that. Mm-hmm.
Question about the new synchronous audio video codes that we're not using yet. I understand that you all can advise about coding but not billing. Are you in a few months able to look at data from PCC to see if in general payers are starting to pay for the new codes? Is that something you can expect to hear?
Yeah, so the question was basically, we can only give coding advice on this and not necessarily billing advice, but could we provide data around how successfully these are being used? And
Not dollar amounts, but whether they're being paid.
yeah, if they're being utilized. Do we have utilization rate data that we would be happy to share? I don't think we've ever shied away from giving that. So
Yeah, no, we can share it in aggregate. There are people getting paid for it. It seems to be payer dependent, as would surprise no one.
Is it regional also?
I have not noticed a regional effect. I didn't look at it regionally. We were looking at it just presence or absence, because the reluctance and the sheer number of denials that came in through the first quarter, people shied away, or the folks that are more adjustment averse didn't want to bother with it. But utilization by by PCC practices is definitely there, and payment is coming in not super well, not great coverage. That's a word that's used so many ways in this context. The number of payers that are making payment on it and acknowledging them and not still requiring E&Ms with modifiers is low, but not non-existent. It's a non-zero.
In Maryland, and this is true in some other states also, there's telemed parity for EM currently. My concern is if there's a separate code, that will be a backdoor around the telemed parity. So our office has decided until we actually see denials coming in for the GTs, which actually GT 95 is a whole other question, in our code, we're not switching over. Does that make sense?
Yeah, so the question is, if we've got, this practice is in Maryland, and there's E&M parity, E&M telemedicine parity. So the reluctance to move away from the codes that are working, which is the G-series codes, is pretty great. So is that okay? The coding answer is always code to the greatest specificity. So if there is a 5-digit, sorry, Tom, if there is a 5-digit CPT that matches what you're doing more accurately than a modified different code, or even more so than the HCPCS code that it sounds like you're using currently, code to the greatest specificity, use what matches best. With that, if your payers are paying it and you've got a written policy from them saying this is how we pay telemedicine, follow that policy, because you know that their propensity will be to wait 8 months, 10 months, and then say, no, these codes were released and effective January 1st, 2025. We're taking all the G code payments back. And they'll make you jump through hoops to get everything that you were due, and then say that some of the things are denied for timely filing. So staying up to, and I know what I'm saying. I know the difficulty of staying up to date on the policy changes that they throw at you. They don't make them easy to find. And the safest way to hang on to the money that you get for the service that you render for the codes that they change, all of that is best done with their policies in writing, following those to the letter.
I will also add anecdotally from at least communications of practice talking about, hey, are you getting paid on these? There is much better luck with the audio video codes. A lot more problems reported with the audio only. So again, like Jan said, it's work with the payers, figure out what they're requiring of you. But I know at least some payers that are paying are much more likely to pay the audio video codes. The audio only codes still seem to have a lot of pushback from payers, unfortunately. All right, we have new labs. So we have the HPV, we have strep, and H. pylori as well. So again, our new lab codes added in this year. We have some that are changed. So again, very minor change, but they did add the words pooled result to the end of the 87624 code. So just as a note for that. New vaccines, we have the 90684, 90624. We have new vaccine admins, so this is going to be your 96380 and your 96381s. These are going to be used in conjunction with the 90380 and the 90381s. New flu vaccines for this year, so we have the 90637, 90638, and 90695. There was a change to this for the 90661, so they actually struck through the preservative and antibiotic-free, so this particular product right now is only just marked as antibiotic-free, not preservative-free as well. We have some older flu vaccines that were removed, so your 90630, your 90654. And then a big change for COVID vaccines. So the only previously used COVID-19 vaccine product that is in use for this update is 91304. That was one that was being used previously that has carried over and is still allowed to be coded. There is one admin code for all COVID-19 products as of this update, 90480. So if you're using that, just make sure for your claims this year that you're not utilizing any of the old admin codes. If you have billing config in your system to point to that to use those old admin codes, you should only be reporting that 90480. One thing with that 91304 is the preservative-free has been removed from that as well, so see the strike through there. And then these are all of the new vaccines for COVID that were added this year. We have the 91318 down through the 91322. And again, that one single admin code that will be used for all of these products now is the 90480. So no longer will you have what you'll see here in the next few slides of all of these different varieties that you used to use. So all the different years, we have slide number 1 of COVID-19 vaccines that were removed. Slide number 2 of COVID-19 vaccines that were removed, and all the admins as well. So ideally, this should make things a lot easier for you and not have to figure out and balance, okay, well, here's the vaccine and here are the 3 different admin codes, or here's the admin code for these 4 vaccine numbers that all start with zeros. And yeah. These are more resources for you. Again, AMA lab testing and vaccine codes, and AP immunization coding table. With that, I just always like to say, please go online and look at the addendum. These are things that we have pulled that we feel are going to be relevant for your practices, but please look through, because there may be something for your particular patient population that really sticks out. Could be things for a small amount of patients in your office that have more complex issues going on that is relevant to them. So please go through and review all the addenda. And I will add one other thing for one final slide here, is that we were able to sneak in some new product codes for July 1st, 2025. As a big, huge caveat for these are all awaiting FDA approval. So while the codes exist, they are technically active as of July 1st, 2025, so they're active now. There's a big lightning bolt next to all these in the update files that say these are not FDA approved yet, they're pending approval. So you may or may not have these in time for the end of the year or beginning of next year. We don't know. If the FDA decides that they are not going to approve some of these product codes, I'm sure there'll be a later update coming in and stating that it's not going to be added. As of now, these are going to be added. If they do stay, they'll be added to the 2026 CPT manual. That's going to be updated there. But these codes do exist, and we'll see if the FDA approval comes in for those. Just a quick reminder always to fill out the course survey in the app. But do we have any questions from anyone? Okay. Do you want to do a walk around this time? Yeah, I think we're going to, since we have some time, and
For the folks online.
do a walk
I
around.
have questions related to coding/billing for a certified lactation consultant who is employed by us. I know, it's like a big sigh. There's questions about charging the baby, charging the mommy, what's double charging, what's allowed. Sometimes we'll have the baby also quickly seen by a doctor to go over a weight loss or a bilirubin, and then it's easy. You just code the baby as a 9921 whatever. If they're only seen by the LC and the LC is also billing the mom, is it only a 99211? Or there's one code, I have a bunch of codes to ask you about, but I don't want to take everyone's time. But there's one code that's like per 30 minutes, and I don't know if they're spending an hour with the pair if they charge 2 units to the mom, or they choose 1 30-minute unit to the mom and bill 1 30-unit to the baby. I don't know if any of that makes any sense, but we're looking at the S9443, S9445, 98960. What do we do?
What a great question. I don't know.
And I was going to say, I am so going to
honestly.
lean on you on that one.
Oh, sure. Now,
Yeah.
now you're quiet.
The other question is she qualified or not qualified? She is certified.
Oh,
Certified by state.
so is the lactation specialist.
She's a Q, and I don't know if she's really a Q or
Ooh, yeah. Okay. So a bunch of things to unpack there. Number one, I do not have a silver bullet for this question that I get frequently, and I have to soothe myself that I don't have all the answers. I like having answers. I don't have this answer. The AAP put out a guide years ago that I have not. Has anybody seen an update to that guide? Is there a 2025 version? I haven't seen it either. So the considerations in this kind of billing are, like you said, baby or mom, or both. Many practices are not interested in registering a mom and billing adult medicine and fighting with payers to prove that you're qualified and that someone in your practice is qualified to consult and serve an adult population. That's one consideration, is the labor. Another is the service, who is the service being rendered to? The baby is your patient, so please don't feel, I encourage you to feel empowered to bill under the baby for whatever service you facilitate and is rendered in your practice for the baby. It's not divorced. You don't have to worry about not getting paid because you're not billing the mom. This is baby service. You're getting this baby fed. What could be closer to keeping that baby alive? Whether it's E&M service or not, the question that you asked about whether the qualified LC is considered qualified by AMA or just the payers or just your state or just the region, qualified, as I understand it, means someone who can bill E&M. So when they say other qualified healthcare provider, they mean NPs, PAs, someone who is individually credentialed and could bill E&M on their own. So in my interpretation, no, that is not somebody that can bill on their own. As for how you bill for their time, the reason that there's confusion around this is there are several approaches to it. You could require that the clinician be part of that care so that you can say this is an ancillary service to an E&M that the clinician then bills. That is still complicated because you can't bill for the clinician's time if they're not in the room providing the service personally. So it is a service. It's not, that service is time-based, but it's not the clinician's time. So it doesn't make it any clearer. It's hard to even say that you've now got an easy way to decide which E&M level it is, because it's a treatment in essence. So you don't have a separate CPT code for it like a nebulizer, but it is treatment that was rendered. It is care and advice and observation and guidance that was provided to them. So some of the time-based codes for clinical staff are what I promised someone at breakfast that I was going to look into to see. The things that are off the top of my head are prolonged care, and that's not necessarily it. It's not as if you spent a protracted amount, like the clinician spent a protracted amount of time, or that kind of care took more time than is usual for that sort of service. It just takes time. What's that? Under supportive care. So is there a way that you know to bill? Oh, I know. That's what I keep coming up against. There must be some, but I haven't found it. So I'm going to continue looking. The Board of Pediatrics insists.
The proper treatment for influenza virus is supportive care, whatever that means, cleaning up the nose, keeping the oropharynx pattern, you know.
So for lactation, same thing, it's supportive to the patient.
Supportive, yeah.
Yeah, because you're supporting the
So
baby.
you're not seeing a way.
Yeah, you're not giving medication, but the cleaning of the baby and making sure the breathing is good, etc. is a supportive. Yeah, that's the care. There should be a code for that.
lactation, right. Gotcha, okay. I have like an, I'm sorry, I have an adjunct to that because,
Can I just wrap up? Yep. So I will promise to put something together with what I find, and I will share that. We will find a way to disseminate that.
Yeah.
I have all sorts of folks.
now, like a adjunct to that is now the Academy of Pediatrics wants the new mothers to be assessed for depression. So if you give them a PHQ-9, depression, that's a standard scored instrument, are you billing it under the baby? So you give that to the mother, but you bill it under the baby?
Yeah, that one in particular, I can chime
Yes,
in,
please.
Capital Up. Yeah, that one in particular is actually, you'll see with the code, it specifically says caregiver focused.
Yeah.
So the code itself for that particular screening, there's notation to say that while this is in care of the child because the screening itself is caregiver focused. So it's not for the individual. So you'll see it in the full, I'll see if we can find the full description for you, but it actually does say caregiver focused for it. So that would be how you would be able to build that particular screening underneath the patient.
So why can't you do that with lactations? Caregiver focus?
Because it's specifically a screening code.
Yeah.
It's a caregiver-focused screening.
Yeah, the screening codes themselves will have that in their description.
Yeah, I'm sure. I have it here.
Because
I wanna get it.
unfortunately,
We'll get it.
I'm just,
Thank you. 96161 is the caregiver-focused screening. I interrupted
I'm
you.
such a rule stickler, and it's not a good thing.
Hey, it makes you a good coder, though.
Yeah.
You're not going to fall outside.
I think Althea's raising her
Yeah.
hand. We have a couple questions on the chat as well.
Two questions in the chat.
Thank you.
Okay, one question was, has anyone used HCPCS code for interpretation services? That's T1013. Any luck getting reimbursed? And do you bill for interpreter services at all, or just cost of business?
So is anybody familiar with that HCPCS code, and have they utilized it? Because I'm not a doctor, I haven't used it.
Yeah, so the T1013, anybody using interpreter services and billing that HCPCS?
Unfortunately,
yet,
a lot of-
Anna.
Unfortunately, a lot of head shakes, so.
Yeah, we do have some utilization and payment information for 2025, and I'm not able to get to it quickly enough to give it to you. But similarly, we really just ought to start a thread for Jan's research posts after posts. HCPCS,
HCPCS.
HCPCS. It's a healthcare procedural common.
Oh, you're putting me on the spot here.
You're studying for your test. You should know this one.
I'm not studying anymore. I already
Healthcare
passed it.
procedural common. Yeah, HCPCSdata.com. Yeah. And another question that came in chat. I'm not refreshing somehow. I'm not seeing the other question. I'm not refreshing.
You're very refreshing, Jan. Okay, a question about 99408 and 96127 on well visit. Most pay 96127, dent 99408. Can you tell I'm not a coder? As an included service. Curious if others get this paid. And there are a couple lactation resources as well.
Thank you, Dr. Namani. There are lactid.org resources that were posted, so if you all aren't in the chat for this session, check it out. Thank you.
Brief question for Althea. Do we save chats along? Are they accessible after the fact?
I think they go on for a while.
Okay, so yeah,
Yeah.
if hopefully those will then also be accessible to you after the fact if you can go on the app.
Yeah, so the question that's still hanging, 99408 and 96127 on well visit. Most pay the 96127. 994. Oh, and deny 99408 as an included service. Curious if others get paid for this. Anybody seeing those denial and payment combinations? We've got a very quiet group, I'm afraid.
Yeah,
We can.
Yeah, I'll chime in just in general, like that it may end up being one we can, again, for the research list that we can do,
Yeah.
looking up, because sometimes there are limitations with what codes are actually allowed to be built out together, but oftentimes it may be something where the payer themselves are stating that this particular thing is bundled in with well care. They're doing that more and more often these days, where this particular screening is considered well care, so you would have to send it out with a modifier to mark that it is a distinct service. So it may be that particular case for this one is that maybe we'll have to check if it's appropriate, but the 5-9 modifier, something along those lines to note that it's distinct. We would have to dig in a little bit more to make sure that there aren't any other interactions where this code is actually not allowed to be billed with this, but it could just be that case.
Yeah, those pair, the pairs, NCCI edits.
Yeah, the NCCI edits.
Yeah.
Thank you.
And one additional question I do see is just someone following up on that caregiver assessment. Are people having success getting paid for the caregiver assessments? Lots of nodding heads. So yes, please do. And I heard Brian make this point earlier today. Bill for it. Don't let a denial or a 100% write-off dissuade you from billing. It wasn't you, it was Ben, I apologize.
I said a lot yesterday, so.
And it's day 2 of 3. I'm cross-eyed. The idea that a service doesn't get paid when you are billing appropriately and using the perfect code for it doesn't mean you shouldn't be billing it. One of the things that billing these services, no matter their reply, it gives you a data set to work with. So you're going to have the opportunity to look back if you go to renegotiate a contract where a payer is not paying you those 96161s, you can say to them, hey, look, we're not getting paid what we're worth. We're thinking about probably dropping your plan. We want to get paid for everything that we're billing. And here's to the tune of this number of units in the last year. We have verified that kids are safely being cared for. We've been adding value and confirming safety, caregiver safety for newborns. Who's more valuable to you than the newborns? That's the thing, though. They don't want to pay for those newborns. And but it does give you some leverage. You have an idea. My favorite example of that concept is the holiday codes, the holiday and after hours codes. How many people are billing the 99050?
Great.
I love you all. This is so one of the responses to that question is, but we're going to stop now because the G2211 pays more. But not in Georgia and in Maryland. See, this is why I don't answer billing questions.
Yeah.
So if you know someone in the room in your state and you're having different experiences with specific codes, I want to talk to you offline about that, not billing that anymore because the G2211 pays more. They are not exclusive. They are completely distinct codes. The G2211, for folks who aren't billing, is everybody billing the G2211?
Yeah.
No.
Yeah,
Getting
the 20
some
the-
squirrely squiggle necks over here.
You,
Okay, so this is billing nonsense. That is negating some of the
Yeah.
codes.
because, yeah, so I'll change, I have been on my G2211 soapbox so much lately.
Take it away. Take it away.
So as far as like the 25 modifier being the thing that blocks it, yes, in reality it does. I have a whole other slide deck that's rather short, but basically Medicaid says that G2211 can be used on, like, especially with like wellness visits. We get that question asked a lot. If you have a well visit coming in and they're also sick, can you also put a G2211 on it? And there are only 2 HCPCS G codes that you are technically allowed to use that on. However, the verbiage and what they use in their release to show the rules says their annual wellness visit. You would think that would cover their well visits at least once a year. That's not the case. They have their specific AWV, annual wellness visit, is only those 2 codes, and I think potentially one other in some cases. But it's a very small subset of codes, and the 9 series of codes that you are using do not fall under it. So unfortunately, pretty much if you have a 2.5 modifier on something, with the exception, there are some immunization codes and admin codes on there. If you find that rule or ask me, I'm happy to try to dig that rule up and send it to you. There is actually a code list at the bottom of that rule that says these are everything that is allowed, or more, these are the only things that are allowed to be used with that 25 modifier with the G2211. The thing I would say, the coding side of that, I would be curious why you would need to use a 2.5 for the after-hours service, unless that is a payer thing where they're just not paying you if you don't put it on, which, because the whole idea of that after-hours code or the holiday codes, those are add-on codes. They themselves are listed as an add-on code. So it should theoretically, you should not have to put the 2.5 on it to get that to be paid. Again, coding side, shouldn't have to. Billing side, the payers may have some weird filter that they have in their EDI servers that say, we're not paying these unless they have a 2.5 on them. So it would definitely be something to look and check.
I'm so proud.
Yeah. So
You're killing it.
yeah. So yeah, please, I would actually be a great case. We can try to see if we can find examples of it. You're shaking your head a lot. If you have examples, you can meet up and tell us.
I haven't done the 5.0, I can cross-reference, but I can't get it quickly. I have my G2211.
We also can snoop on your server.
So just to try and get a little bit up to date for the folks that are remote and virtual, some folks are saying that they don't get the holiday codes paid, and that is kind of the point. If you are billing for those holiday codes and again, you come up to a contract negotiation and say, you have not once paid me for a holiday when I took time away from my family, maybe had staff come in, had to pay them overtime to see patients, and I kept them out of the ER. If you want to start paying ER prices, I'll stop seeing our patients on holidays. I just won't extend that service. I'll stop extending that service to patients if that's really your preference. And when they know the numbers, they know that when you push back on that paying you the difference of a 99050 is going to save them money as opposed to ER charges. So do it. Be brave. We're here with you. We're right behind you. Build those. A write-off is a write-off is a write-off, but when you build that data set, you've got some leverage.
Before we take a couple questions, I realized I had one, it's not on a slide, but I did have a couple things to note. And then we'll get to more questions just so that we don't butt up into time and have that stuff go out. Because we did have a rule update happen on July 1st for ICD-10 codes. Just a few things I wanted to keep just to notify, and this is a PDF I have on my phone of the stuff I've looked at. Just a few diabetes changes, but more specifically, we see a big increase in additions for for addition of egg and milk when it comes to diagnoses of whether it's a reaction based on baked or not. So it's a small difference, but they've added a lot more specificity. I will read out one of these specifically. Other adverse food reactions, now the code I'm looking at is a T78.111. Other adverse food reaction due to milk and dairy products with reactivity to baked milk. So that extra wording that they're adding on there, with reactivity to baked milk or with reactivity to baked eggs, those are a big difference. So if you're looking at any of those kind of allergies at your practice, you'll definitely want to look at the updates and see if that may be something that's more specific for those particular patients. And then a few slight changes to diabetes codes. Again, I think we said we were going to look at adding those into the drop-in for informational in August. So, but just again, that little quick point, and then we'll get back to questions.
I think we're caught up.
And we had some in the room as well. We had questions in the room? Yeah.
Can you go over some of the 2025 definitions of fine points between 1.3 and 1.4, such as what are systemic symptoms? And
So
not chronic getting worse, but if you have an acute illness that's you've seen them the next day and they're getting worse, but they don't have systemic symptoms, like their fever's higher, they have our office is undercoding according to the PCC dashboard. And we're trying really hard to follow the rules, and we're not doing well compared to the other PCC practices, and I'm trying to figure
So I'm going to give you the longest non-answer that you probably don't want. With regards to systemic symptoms, I need to find my slides for some of the E&M audits that we do. It is really so specific on what the provider is feeling it's reaching at that point. From the AMA, they had a publication that went out that I, again, still felt was a pretty big non-answer from them about it. And it was basically if you have a patient where the extra symptoms that you would be borderline looking as systemic, if that is a higher risk to the patient because they have those, that was where they felt that was more apt to bring that up as an acute with systemic. So if you have a baby with a really high fever, where that's higher risk of morbidity with those type of symptoms, where it is, again, a higher risk to that patient, they would say we would feel more comfortable with a provider listing that as acute with systemic. But they did not give a hard and fast, these are symptoms, if I really wish they would, like fever over this amount is considered systemic, or you have vomiting and wheezing, anything else that may be considered something systemic in a particular case versus another may be more of a risk to that patient. That's all they're really saying, is that if it really is up to the provider. And that may just be something at your practice, is that you're feeling like you don't want to branch it up to that point because it doesn't technically qualify, but I've not been able to find anything that has a hard and fast rule about it. There's communication online, there's debates all the time between providers about what they feel is systemic and what isn't. I'm sure we'll have many answers if we ask that out to the room today about where that would land. So unfortunately, we would hope that something like from the AMA would be great to actually give us, or AAP to give us something more specific, but they don't, unfortunately. They say it really is more up to the provider.
And while I want it in writing, while I want chapter and verse to give to you, the thing that I'm going to say is more important is document what you believe is happening with that patient that day. Hearing you say that our dashboard scores are not like our peers on the PCC side of things, the way that dashboard score is calculated is it looks at the percentage of level 4 and level 5 services, and it's only established patient. The percentage of level 4 and 5 services that you bill as a ratio, that's the numerator. The denominator is 100% of your sick visits. What that says to me is that score is a measure of how complex your coding is. That's half the story. The other side of that story is your documentation and what actually happens in your exam room, the kind of patients, the diseases and problems you're treating. So if you have a subspecialist in your practice, yeah, I'm going to expect to see a lot of 4s and 5s. You're going to be diving deeper. You're going to be spending more time. You're going to be ordering more tests. If you have a whole lot of NPs and PAs that you've got doing very run-of-the-mill routine sniffles kind of sick care, you're going to have mostly 213s. And when that matches your encounters, you're doing great. Please, please. The most important match is not between you and your peer. Is Tim Proctor in here? Don't tell Tim. The most important match is between what you do in your exam room and the levels that you bill, not between what you bill and what your peers do.
One real quick follow-up.
Yeah.
Am I correct that if you have a Hoover and you document why they don't need steroids, does that count as prescription management?
Can I come back to that one?
Yes.
I want to give anybody, you guys have had a couple questions. Does anybody else have questions before we have just 2 minutes left? Was that oh, that was a high sign. No, she's just praying back there.
No. I was just wondering about the social determinants of health, adding to the complexities. So if you have somebody that's living in a shelter with no air conditioning and they are presenting a child with a fever, is that now shooting up your...
The risk. That would factor into risk, maybe. So the question, that question all hinges on whether that social determinant has an effect on their ability to carry out that care plan. So it's not that they are in a shelter, it's that being in a shelter is going to continue to expose them to things that are not going to, are going to complicate their care. They have poor access to transportation. They're not going to be able to get to the specialists. There you go. Yeah, so if they don't have air conditioning and they're not going to have any reasonable expectation of having easily breathable air, that would complicate their ability to heal from that and they have asthma. Yeah, so document all of those things, and yes, but that they are in a food desert and can't get somewhere, it's not the presence of SDOHs, it's the relevance of SDOHs to the care plan. We are at time now, and there's one more question online. If it's a quick one, we can do it.
I think we have
Hit me.
Okay, the question is anyone billing the patient for 99051 or G2211 when denied by the payer?
That's a good one. Is anybody in the room billing the patient for after-hours, holiday codes, and G2211 when the payers are zero pay, passing the charge onto the patient responsibility? If it's on the EOB and the patient is responsible, yes, there are nods and hands in the air in here. Thank you all so much. I know there are more questions than we have time for. Hit me up at a meal. Better yet, hit up Mr. Brian Kennedy.